Unit 3, Therapist, Counselor, and Client Relationship. 3.1, Introduction. Each of us would have both sought from and provided guidance, advice, and help to family, friends, and acquaintances in an informal manner. In some ways, this may appear similar to a relationship between a therapist and client. However, the therapeutic relationship differs from a personal relationship in a number of ways. The therapeutic relationship is a professional helping relationship wherein the interests of the client always come first. The onus is on the therapist to create a safe environment that facilitates communication. Social conversation is often laced with casual advice, suggestions, recommendations, and even firm demands. Unlike other social contacts, the therapist is a trained professional who uses appropriate techniques and skills that may help the client. The client can take certain aspects of the therapeutic relationship for granted. For example, the confidentiality of communication within the interaction. The reciprocal nature of social interactions is not typical of therapy. The client remains the focal point of the discussions, and there is always an inherent power imbalance present in the relationship. Unlike casual social contacts, the therapy sessions are planned with a specific beginning and end. The therapeutic interaction also involves collaborative planning of goals. The interaction is also time limited as therapy moves towards a planned termination. People often develop a close relationship with their therapist. The two of them have been sitting in a room talking about very personal subjects, often once a week for at least several weeks. Does this make them friends? The therapist usually does not see it that way. Specific boundaries define the therapeutic relationship. It is sometimes difficult to achieve a sense of objectivity in close personal relationships. Therapists need to understand their clients' emotions, but also keep the appropriate emotional distance in the relationship. Although the therapeutic relationship is a collaborative relationship, rich with feelings and a sense of connection, there is a certain degree of inherent objectivity. This unit focuses on the role of the relationship between the therapist and client during family therapy. Objectives. After studying this unit, you will be able to define the concept of the therapist-client relationship, describe the role of the therapeutic relationship in different modalities of therapy, explain the client, therapist, and therapeutic technique-related factors associated with the formation and maintenance of the therapeutic relationship. Discuss the relationship between the therapeutic relationship and therapy outcomes. Illustrate the ethical issues pertaining to the therapeutic relationship. TER 3.2, Evolution of the Concept of Therapist-Client Relationship. Therapeutic alliance is not a new concept for clinicians, and it has a long and rich history. The recognition of the importance of the therapeutic relationship can be traced back to writings on psychoanalytic theory by Sigmund Freud. Freud recognized the value of the contract between client and therapist and the significance that the therapist's attitude had on the outcome. He explained that when the therapist invested in a relationship with the client was able to form an attachment with the therapist. In addition, he recognized the importance of that relationship from the beginning by explaining that any therapeutic success would be lost without it. Freud, 1912, 1966b. The central component of Freud's analytic work was the interpretation of transference, the client displacing repressed wishes, fantasies, and aspects of past relationships from childhood onto the therapist. Freud, 1912, 1966a. The therapist then used this transference, interpreted it, and assisted the client in being able to rationally see that projection as distorted. Freud began to question why a client would endure this and still remain in therapy. Freud, 1912, 1966b. He concluded that the client was able to view the therapeutic relationship as positive aspects of previous relationships, and that the client could bond with or have an alliance with the therapist to work together to fight against the client's negative past experiences. Sigmund Freud stated that transference of friendly or affectionate feelings, which is admissible to consciousness and unobjectionable, is the vehicle of success in psychoanalysis. Freud, 1912, 1966b. Anna Freud pointed out that, apart from transference, we should leave room somewhere for the realization that analyst and client are also two real people, in a real personal relationship to each other. Uh, Carl Rogers defined a helping relationship as a relationship in which one of the participants intends that there should come about, in one or both parties, more appreciation of, more expression of, more functional use of the latent inner resources of the individual. 1961. He placed the therapeutic relationship at the center of the healing process and believed that it was necessary for the therapist and client to have an authentic relationship initiated by the therapist for therapy to be successful. The therapist's main task was to establish a relationship that was accepting, empathic, supportive, and genuine, and the remaining elements of a successful relationship came from the client, Rogers, 1957. Rogers believed that for personality change to occur, certain conditions had to exist and continue over a period of time. Those conditions were: two people had to be in psychological contact, the client would be vulnerable and anxious, the therapist needed to be genuinely invested in the relationship. Rogers discussed the vital importance of the clinician to freely and deeply be herself or himself. The clinician needs to be a real human being rather than an all-knowing, all-powerful, rigid, and controlling figure. All facades should be left out of the therapeutic environment. The therapist needed to have unconditional positive regard, accepting each aspect of the client's experience without any conditions for the client. The clinician needs to care for the client as who they are as a unique individual. One thing often seen in therapy is the treatment of the diagnosis or a specific problem. Clinicians need to treat the individual, not a diagnostic label. The therapist needed to have an empathic understanding of the client. An accurate, empathic understanding of the client's awareness of her or his own experience is crucial to the helping relationship. It is essential to have the ability to enter the client's private world and understand their thoughts and feelings without judging them. And the client perceived the therapist's interactions as acceptance and empathy. These 6 conditions were considered to be both necessary and sufficient for therapeutic client change to occur. Greenson, 1967, referred to the therapeutic alliance as the client's ability to work purposefully and decisively in treatment, and thus was the first person to use the term working alliance. The client was seen as contributing to the alliance by being motivated, willing to cooperate, and being able to follow the instructions and insights of the therapist. He maintained that a reality-based positive collaboration between client and therapist was one of the essential components for therapeutic success. Borden, 1979, took all of these views into consideration and fused their contributions to redefine the working alliance. According to Borden, the alliance is a conscious, collaborative relationship between the client and the therapist. He distanced himself from the idea that a working alliance accompanies transference and viewed the alliance as a vehicle that facilitates the effectiveness of therapeutic techniques and processes. A successful therapeutic alliance consists of 3 aspects, which are as follows. Tasks. Having an agreement on therapeutic tasks, including activities that the participants engage in during their therapeutic sessions, such as role play and cognitive restructuring. The tasks need to fit the client's lifestyle, worldview, and expectations for therapy. Goals. Having an agreement on therapeutic goals, wherein the client and the therapist agree about the targets of change while in therapy. And bond. The bond, a mutual fondness, attachment, and trust between the client and the therapist. The clients must also perceive that the therapist is truly interested in helping them to achieve their goals. All 3 components illustrate the respective roles and responsibilities of each participant in successfully achieving the goals of therapy. The working alliance is what makes it achievable for the client to accept and follow treatment, and in order to be most effective, the alliance needs to be mutual. Borden, 1979. The nature of the therapeutic relationship may well reflect the differences between typically individualistic Western cultures and traditionally collectivist cultures, such as in India, the Middle East, China, and Japan. These societies emphasize interdependence rather than independence and view the individual in relation to social roles, obligations, and situational restrictions. Kakar, 1997, Rowland, 1988. The Guru Chela model of the therapeutic relationship has been proposed in India, Necki, 1976. The therapist is seen as a benevolent authority figure and assumes a role with more activity and direct guidance and advice. Unlike the Western models that require personal responsibility and decision making within a collaborative therapeutic relationship, Indian clients may assume a submissive position and expect a more directive attitude from therapists. 3.3. Role of therapeutic relationship in different modalities of psychotherapy. While all modalities of psychotherapy agree on the importance of the therapeutic relationship, there are differences in their conceptual understanding and the relative emphasis on its role. However, 3.3.1, Psychoanalysis and Psychodynamic Psychotherapy, Sigmund Freud emphasized three principles as crucial to the therapeutic relationship in psychoanalysis. These are anonymity, neutrality, and abstinence in psychoanalysis. Traditionally, the analyst strove to remain as a blank screen in a non judgmental atmosphere, neither approving nor disapproving of the client's wishes and fears. Abstinence implied that the analyst should abstain from revealing herself or himself, while anonymity referred to staying anonymous or unknown. Transference and the here and now collaboration between therapist and client together make up the therapeutic alliance. In other words, the client would begin to experience in the relationship with the analyst unconscious conflicts experienced with significant others during childhood. Working through this transference was the key avenue for change in psychoanalysis. The analyst's countertransference, unconscious feelings about the client that stem from the analyst's own life experiences and issues, also influences therapeutic interactions. Alexander and French described the importance of the corrective emotional experience in psychodynamic psychotherapy. Ideally, the therapeutic relationship should provide a new experience that most effectively counters the client's maladaptive interactional patterns. For example, if a client was raised by an intrusive mother and tends to replicate this pattern in interpersonal relationships, the therapist must respond and behave in ways that counter her or his expectations of intrusiveness. This new emotional experience in the therapeutic relationship itself may be the cornerstone of therapeutic change. 3.3.2 Client-Centered Therapy. Rogers, 1957, held that the therapist's primary effectiveness is through the therapeutic relationship. The therapist must show empathy to the client, be genuine with the client, and have unconditional positive regard for the client. Showing empathy requires understanding the client's feelings and reflecting them back to the client to help them understand these feelings as well. Being genuine involves being open and honest with the client and sometimes self-disclosing to help the client feel the therapist has empathy. Having unconditional positive regard means valuing clients as people without conditions of worth. Rogers holds these therapist characteristics and behaviors, along with the client's ability to perceive these characteristics as both necessary and sufficient elements of therapeutic change. Various studies empirically support the importance of these therapist characteristics. While Rogers acknowledges that therapeutic techniques may be helpful to the client, they are helpful only to enable the client to gain a greater sense of self-efficacy. However, this end is mostly accomplished by unconditional positive regard of the client by the therapist. Thus, the therapeutic relationship is important as a primary factor in psychotherapy and as an end in itself. 3.33 Cognitive Behavior Therapy. Beck, 1995, used the term collaborative empiricism to characterize the relationship between therapist and client in cognitive behavior therapy. Therapist and client work together using a rational, logical approach to understand and test the client's thoughts and assumptions. Cognitive therapy emphasizes the role of a collaborative relationship in which the therapist-client team mutually decide on the problems to be discussed, rationales for intervention, homework assignments, frequency of visits, and so on. The alliance is strengthened by the focus on eliciting and responding to clients' feedback. The therapist is active and goal-oriented and plays an educative role. The cognitive behavioral therapist understands the importance of relationship issues as they affect the primary goals and the effectiveness of cognitive behavioral techniques. The therapeutic relationship is seen as a secondary factor of therapy. 3.3.4 Supportive Psychotherapy. The internalization of the positive real A therapeutic relationship is considered the primary fulcrum for change in supportive psychotherapy, more so than in many other modalities. The stance is empathic and active in helping the client improve her or his coping and social functioning. The conversational style is more informal, and the therapist may engage in relevant self disclosure. The therapist may serve as an alter ego by acting for the client in relevant situations with others and help solve problems. At the same time, a dependent therapeutic relationship must be avoided. Unlike psychoanalytic and psychodynamic psychotherapy that emphasize the transference, supportive psychotherapy focuses more on the real relationship between client and therapist. STI 3.3.5 Couples Therapy. The first formal definition of therapeutic alliance as it applies to couples therapy has many similarities to the concept of working alliance in individual therapy, Pinsoff and Catherall, 1986. However, some important differences and clinical considerations are also highlighted. The therapeutic alliance in couples therapy consists of the collaborative bond that exists in therapy between the therapist system and the client system. The alliance comprises two dimensions. Content dimension encompasses A, the effective bond between clients and therapist, B, agreement on the goals and objectives to be pursued in therapy, and C, agreement between clients and therapist on the tasks and methods used to achieve the goals agreed upon. Interpersonal dimension covers A, the alliance between one spouse and the therapist, B, the alliance between the other spouse and the therapist, and C, the alliance between the couple and the therapist. When doing couples therapy, the therapist needs to work with two clients and multiple systems simultaneously, bringing about unique challenges, demands, and processes. Garfield, 2004. In other words, the couples therapist needs to build and maintain an alliance with both partners, as well as with the couple system. Garfield proposed that, when working with couples, there are three different therapeutic alliances: the individual alliance, where each member has her or his own alliance with the therapist; the subsystem alliance, the alliance with the therapist as a couple; and the system alliance, the alliance with, among, and between the couple and the therapist. Consequently, there is a greater likelihood in couples therapy than in individual therapy for at least one relationship to develop poorly and thus increase the risk for premature termination. Regardless of what brought them into therapy, both partners may attempt to form individual alliances with the therapist in hopes of the therapist taking her or his side. Split alliances occur when the perceptions of the therapeutic alliance are significantly more positive for one spouse than for the other. Pinsoff and Catherall, 1986. Strategies to solidify the therapeutic relationship in couples therapy include the therapist's efforts to avoid splits and alignments with one spouse, and the need to keep marital distress versus individual symptoms as the primary focus of treatment. In addition, identifying the partner's early family of origin distress can help predict and respond to strains in the therapeutic alliance that may occur later in therapy. Finally, the therapist needs to help the couple to balance the power differences in their relationship during therapy in order to strengthen the therapeutic alliance. Garfield, 2004. Sather 3.3.6 Family Therapy. The family therapist needs to establish and maintain multiple alliances within the family system. Validating and supporting the family as a system and attending to each individual family member's experience are particularly important aspects of developing and maintaining a good therapeutic relationship. Diamond and Little, 1996. This is particularly challenging as family members are likely to be in conflict with each other. Inexperienced family therapists often take the side of one family member against another, behaving as though one was right and the other was obviously wrong. In establishing relationships with the family, the therapist must join all family members, not just those with whom she or he agrees. In fact, frequently, the person with whom it is most critical to establish an alliance or bond is the most powerful and unlikable family member. Structural family therapy, SFT, specifies a number of techniques to establish a therapeutic relationship in family sessions and prepare the family for change. One of the techniques is joining, or becoming a temporary member of the family for the purpose of treatment. This is done by tracking Therapist following the content of the family facts to identify the interactive patterns in the family and to determine which of these patterns may be causing the family's problem symptoms. Mimesis. Therapist becomes like the family in the manner or content of communications. Confirmation. Using a feeling word to reflect an expressed or unexpressed feeling of a family member. And accommodation. Therapist makes personal adjustments in order to achieve a therapeutic alliance. 3.3.7 Group Therapy. Cohesiveness within the group is considered the equivalent of the therapeutic working alliance in the group context. Cohesion generally refers to the emotional bonds among members for each other and for a shared commitment to the group and its primary task. Cohesion defines the therapeutic relationship in groups as comprising multiple alliances, member to member, member to group, and member to leader, that can be observed from three structural perspectives: intrapersonal, intragroup, and interpersonal. Intrapersonal cohesion includes members' sense of belonging, acceptance, commitment, and allegiance to their group. Intergroup definitions of cohesion focus on the group-level features such as attractiveness and compatibility felt by the group as a whole, mutual liking or trust, support, caring, and commitment to work as a group. Finally, interpersonal definitions of cohesion focus on positive and engaging behavioral exchanges between members. These multiple alliances reflecting group cohesion are seen as important mechanisms of change in group therapy. 3.4 Formation and maintenance of therapeutic relationship. Associated factors. Therapist and client-related characteristics affect the strength and success of the therapeutic relationship. Some of the important factors related to clients, therapists, and therapeutic techniques are discussed below. Client factors. For clients, one determinant is the level of motivation. Clients who are ready for change are more likely to have a positive therapeutic alliance with their therapists, stay in treatment, and have better outcomes. The strength of the therapeutic alliance is largely unrelated to diagnosis or severity of psychopathology. Clients with personality traits of perfectionism may have a strong relationship with their therapist in the initial phases of therapy. However, the alliance is less likely to strengthen and build over time. This may be because perfectionistic clients could have greater difficulty in dealing with the normal fluctuations that occur in the therapeutic relationship. Evidence also suggests that the quality of a client's early attachments and family experiences may influence her or his ability to form an alliance early in individual psychotherapy. Researchers have linked insecure attachment styles with poor initial alliances in individual psychotherapy. Eames and Roth, 2000. Ogrodnichuk, Piper, Joyce, and McCallum, 2000. In general, clients who are better adjusted, have better coping skills, and social support at the beginning of treatment tend to form better therapeutic relationships. Some research results suggest the role of gender, wherein male clients prefer a more practical, utilitarian approach, while female clients bond better to a more empathic, caring approach. The centrality of relationships in the lives of adolescent girls and women might make them more sensitive to the relationship with the therapist and also to any fluctuations within the therapeutic alliance. The process of forming and maintaining a therapeutic alliance can also be influenced by the client's developmental stage. For example, adolescent clients may present specific challenges related to cognitive developmental changes and emotional processing during adolescence. Therapists would need to respect their heightened needs for autonomy and intense concerns with trust and confidentiality. Therapist factors. A number of therapist interpersonal styles are associated with positive alliance formation. These include being alert, confident, empathic, engaging, flexible, friendly, genuine, helpful, honest, intelligent, open, prepared, respectful, skillful, and warm. Other therapist factors like rigidity and hostility are negatively associated with alliance quality. These findings point to the importance of self-reflection and observation on the part of therapists. Some research has found a small positive relationship between therapists' experience and the quality of the therapeutic relationship early in treatment, while other studies did not find this link. Chat therapy techniques. Therapist techniques such as exploration, reflection, Noting past therapy success, accurate interpretation, facilitating the expression of affect, and attending to the client's experience have been found to contribute positively to the therapeutic relationship. Tenor Evaluator 3.5 Relationship between therapeutic relationship and therapy outcome. The nature of the therapeutic relationship exerts a powerful influence on how the therapist client encounter is likely to turn out. The therapeutic alliance has been related to successful outcomes in all forms of psychotherapy. Borden, 1979, Horvath and Simons, 1991. The therapeutic alliance functions as a common or pantheoretical factor that influences outcome. Krupnik et al., 1996. It has been estimated that at least 30% of client improvement can be attributed to relationship factors. Lambert, 1992. Researchers have provided evidence that client ratings of the alliance are stronger predictors of treatment outcome than are therapist ratings. Horvath and Simons, 1991. This implies that therapists cannot afford to rely solely on their own perceptions of the relationship, but must find a way to elicit the client's view of it. The early stage of therapy is critical for the formation of a positive relationship between clients and therapists. When compared to the middle and late phases of therapy, the alliance established in the beginning phase of therapy is more predictive of outcome and dropout. Horvath and Simons, 1991. If the therapeutic relationship lacks this alliance from the beginning, a positive outcome is less likely. This has implications for therapists to focus on alliance building as they begin therapy and to have collaborative discussions on therapeutic tasks and goals. Does the therapeutic relationship remain the same or change through the course of therapy? The answer to this question is that the therapeutic relationship is seen as a dynamic, rather than static, phenomenon that is responsive to the changing demands of different phases of therapy. It is possible that the therapeutic relationship may go through strains and disruptions. This should not make therapists despair, as these ruptures can be worked through and repaired in a direct, open, and non-defensive manner. This might even strengthen the therapist-client alliance. It may also be an excellent opportunity for the therapist to gather information about the client and understand what behaviors and events led to the rupture. It would be important to maintain a dialogue with the client and discuss feelings. For example, the therapist could say, "It seems to me that something has changed in our relationship." Successful repair of alliance ruptures has been related to better therapy outcomes. The question of which is more important, the techniques or the relationship, in psychotherapy has been debated over the years. Most would agree that both contribute to the effectiveness of psychotherapy. What emerges is that the therapist-client relationship has a unique contribution to the therapeutic outcome. The alliance is thus therapeutic in and of itself. The relationship may also be a prerequisite for therapeutic interventions to be effective. The relationship allows the client to actively and cooperatively work with the interventions provided by the therapist. To conclude, this view holds that the relationship is a necessary, though not sufficient, element for change to occur. 3.6 Ethical Issues in the Therapist-Client Relationship. The American Psychological Association, APA Code of Ethics, clearly specifies the ethical issues related to therapy and the therapeutic relationship. Some of the important aspects are discussed below. Informed consent to therapy. Therapists must inform clients about the nature and anticipated course of therapy, fees, and limits of confidentiality, and provide sufficient opportunity for the client to ask questions and receive answers. Therapists in training must inform clients of this fact and give them the name of the therapy supervisor. In deciding whether to offer or provide services to those already receiving mental health services elsewhere, therapists need to discuss treatment and client welfare issues with all involved parties before proceeding. Confidentiality and limits of confidentiality. Confidentiality is one of the most important aspects of the therapeutic relationship. Clients need to be confident that their personal secrets, strong opinions about others, or sensitive emotional expressions will not go beyond the relationship with their therapist. Confidentiality and its limits must be discussed at the beginning of therapy. The limits include disclosure without consent only as mandated by law, or under specific circumstances. This includes situations where the client, therapist, or others need protection from harm. For example, instances when a client discusses a suicide plan, intent to harm a spouse, or threatens the therapist. Another situation might involve appropriate discussions with professional colleagues either after consent or with care not to reveal confidential information that could lead to the identification of a client. Dual or multiple relationships. A multiple relationship occurs when a psychologist is in a professional role with a person and at the same time is in another role with the same person, at the same time is in a relationship with a person closely associated with or related to the person with whom the psychologist has the professional relationship, or promises to enter into another relationship in the future with the person or a person closely associated with or related to the person. Therapists must refrain from entering into a multiple relationship if it could impair their objectivity, competence, or effectiveness in the therapeutic role, or otherwise risks sexual, emotional, or financial exploitation of the client. This has been most often discussed in terms of sexual intimacy. Therapists must not engage in sexual intimacy with clients or their relatives or significant others. Therapists should also not engage in therapy with persons with whom they have engaged in sexual intimacies. The APA guidelines also specify that therapists should not engage in sexual intimacies with former clients or patients even after a 2-year interval, except in the most unusual circumstances. In this event, they would bear the burden of demonstrating that there has been no exploitation. The guidelines also imply that it is unethical for a therapist to treat a close friend or relative. It would not be good practice for a therapist to enter into a dual professional role, for example, as a client's therapist and as the same client's employer. Financial relationships, for example, the therapist borrowing a large sum from a client to buy a new car or inviting a client to invest in the therapist's new business venture, are incompatible with the therapeutic relationship. Some other ethical guidelines point to the therapist's responsibility to refer and provide continuity of care in the event of interruption due to the therapist's illness, relocation, or unavailability, or the client's relocation, financial constraints, etc. Therapists should not continue in therapy when unfit to do so due to illness, personal circumstances, or intoxication. Likewise, therapy should be terminated when the client no longer needs it, is not likely to benefit, or is being harmed by continued therapy. There are a number of warning signs that indicate when a therapist may be crossing the boundaries in the therapeutic relationship. Some examples of these are spending time with a client beyond what is needed to meet the therapeutic needs, responding to personal overtures from a client, disclosing personal problems to a client, spending time outside of the therapeutic relationship with a client, and providing the client with a home phone number unless it is required in the context of a therapeutic relationship. When a psychotherapist honors professional ethics, she or he not only protects clients from exploitation, but also creates an environment that facilitates a strong therapeutic alliance and potential for positive change. Let us sum up. In this unit, we have learned about the importance of the relationship between the client and the therapist. Specifically, you should be able to define the historical roots and current concepts of the therapist-client relationship. You learn the similarities and differences in the role of the therapeutic relationship across different modalities of therapy. Now, you can explain the client, therapist, and therapeutic technique-related factors associated with the formation and maintenance of the therapeutic relationship. The unit elucidated the links between the therapeutic relationship and the outcome of therapy. At the end of this unit, we also discussed the ethical issues pertaining to the therapeutic relationship. Alliance rupture, a breakdown in the collaborative process between therapist and client, a poor quality of therapist-client relatedness, deterioration in communication, or a failure to develop a collaborative process from the beginning of therapy. Dual or multiple relationships, any situation where multiple roles exist between a therapist and a client. Individual alliance, each family member's own alliance with the therapist in couples or family therapy. Subsystem alliance, the alliance between the therapist and a subgroup within the family system. System alliance, the couple's or family's shared sense of purpose about the need, value, and goals of therapy. Therapeutic relationship, the technical term for the cooperative relationship between therapist and client that is considered essential for successful psychotherapy. Working alliance, the quality and strength of the collaborative relationship between the therapist and client, measured as agreement on therapeutic goals, consensus on therapeutic tasks, and a relationship bond.